just want to start with a quick disclaimer that my views are my own and don't represent those of my employer, just me. Okay. So it's about 7.5 years ago that my father died after a series of medical errors, and the hospital would not talk to us. And that was the beginning of my journey in patient advocacy for safety, transparency, and patients' rights in healthcare. So Kevin asked me to talk about this term, second victim. You may or not have heard this before. All right. If you go to Google and you put in victim of medical error, it'll give you some results, and it'll give you some suggested similar topics you might want to look into. And if you look at this list, you type in victim of medical error and look what it's returning. It suggests you look at second victim. That's interesting. And when I was going through, my father was a victim of a medical error, and I put in this Google search, and I was kind of perplexed by what I was getting back, but I've come to understand it more, and I'm here to share my viewpoint with you. So if you do a Google search again for victim of medical error, it'll give you a bunch of results. And earlier this year, back in May, I took the top 50 of these and I categorized them. And so each of these bars, gray or red, represents one of these results. So some of them were intended for the patient or family, talked about the health system, maybe legal issues or advocacy or support. Most of the results were for healthcare professionals, a few on response or ethics. The vast majority of results were actually talking about second victim. So this term, second victim, was introduced by Dr. Albert Wu back in 2000 in an editorial in the British Medical Journal. And he was pointing out that medical harm, medical errors, they can be traumatic for not just the patient, but also the nurses, physicians involved. And I completely agree with this editorial he wrote. He was pointing out that people on the care team also need support. And I completely agree with this article, but he introduced this term, the second victim. And that term has taken on a life of its own. So there's now the second victim syndrome, the second victim phenomena, and we've also got third, fourth, and fifth victims. And depending on what author you're reading, this is the list of people and things that are now assigned terms third, fourth, and fifth victims. This term has really taken on a life of its own. Okay, and one reason is because this term is sticky. So this is a book describing what makes some ideas stick. And they have 6 criteria, and this meets at least 5 of them. It is simple, it is unexpected, it's credible, it's very, very emotional, and it inspires stories. And so I think this term has implications for patient safety, and here's why. In my role as an advocate, I'm sometimes in seminars or training sessions with physicians and nurses, and we're to be talking about patient harm. As soon as this term comes up, we're bumped out of the space of patient harm, and we are talking about second victims now. The first time it happened, it was just incredibly bizarre and jarring to me. The second time it happened, I was like, what's going on? The third time I saw this happen, I said, I need to stand up and say something. So I reached out to my network of other fellow patient safety advocates. The 3 most well-known I know were Helen Haskell, Patty Skolnick, and Carol Hemmingard. And I said, I think we need to say something, because I knew the patient advocacy community kind of has a problem with this term, second victim. And now that I was seeing safety implications, I said, we need to say something. And they said, we agree. So I drafted up an article. We discussed it, and we got published in the British Medical Journal, BMJ, which is very appropriate because that's where the term was introduced. So this is my argument, my core argument. Preventable patient harm results from a combination of institutional systems factors and the actions of people within those systems. Without a clear recognition of this reality, the effectiveness of patient safety initiatives is undermined. The second victim label obscures the fact that healthcare professionals and systems can become unintentional agents of harm. This label may help professionals and institutions to cope with an incident of medical harm, but it's a threat to enacting the deep cultural changes need to achieve a patient-centered environment focused on patient safety. So when this article was published, and well, first of all, two things. They changed it to British English, so I feel very special. Some British English. The editors also added that headline. You see that big headline, avoiding responsibility? When I saw that in print, I'm like, oh my God, I was trying to like gently approach that, and they just blared it out. And so when I thought that, I'm like, oh my God, some people are gonna have a reaction to this. And yes, they did. So I did get a handful of emails thanking me for this, and a few online comments thanked me. But this prompted some letters. Oh my gosh, yes, this prompted some letters and comments. Here's a few of the headlines of the letters. So there was a few categories of responses. One was physicians and nurses really are victims. They are victims of the systems they're in, and they're victims of their employer. Okay, and another argument was, we can all be victims. We don't have to be stingy with victimhood, we can just all be victims. Another complaint was that, well, you didn't suggest another term, so we're gonna keep using this term. And that one is kind of a legitimate complaint. So my co-authors and I, we realized we were saying don't use the term, but we didn't supply an alternative. Some people jumped on that. Since then, we've decided, okay, we're okay with the term traumatized provider, traumatized nurse, traumatized physician. You have my blessing to use that term. I think it might be actually much more accurate. So that was an experience. So I think the message that I want to convey to you is, please do not teach healthcare providers to see themselves as victims. That's not going to help any of us. So yes, please just don't teach people to see themselves as victims. So that is kind of, I'm going to switch now to another topic. I'm going to do an abrupt change. Kevin wanted me to talk about this topic, and I said, okay, but only if I can put in another topic. And so, abrupt switch, here we go. This is another very relevant and recent topic, and I've got to talk about this. I work in the area of disclosure. So this is what happens after patients are harmed, as in telling the patient and family about harm. So before I get into what Colorado has done, I want to give you a bit of a background. Okay, so views on responsibilities to harm patients, they vary greatly among policymakers and providers. I'm going to give you an overview of two before I get to Colorado's. So England, over in England, they established what is a statutory duty of candor in 2014. And so it says, as soon as reasonably practical after becoming aware that a notifiable safety event has occurred, a registered person, I guess that's like their physicians, must notify the relevant person, as in patient, that the incident has occurred. And they are serious about this because their Care Quality Commission that oversees their medical system, they can prosecute if the providers or facilities prosecute for failure of notification or inappropriate notification. So England has taken this pretty seriously, at least in their documents. How this is actually enforced, I do not know. Okay, jumping back here to the United States, just to set the ground so you know what I'm talking about. Patients do have a right to their medical records. They do not have a right to information about patient safety activities involving their medical care. And as part of informed consent for treatments, patients need to be told about benefits and risks of harm. However, if harm occurs, patients do not have a right to know about that harm, with some exceptions in that list of a half dozen states. So that's the playing field here in the United States. But yet disclosure seems like it should be the ethical thing to do. Well, we need it. So AHRQ, back in 2016, released what's called the CANDOR toolkit, Communication Optimal Resolution. they have a process. The CANDOR process improves patient safety through an emphatic, fair, and just approach to medical errors and promotes a safety of culture that focuses on caring for the patient, family, and caregiver, an in-depth analysis, event investigation and analysis, and resolution. So that's this program. And so you can go to the website, and they provide on the web, it outlines best practices, there's training material, and it describes the phases of an implementation that an organization such as a hospital would go through to implement this CANDOR. Okay, that sounds like good stuff. Okay, now jumping to Colorado. They also have something called CANDOR. It is quite different. Okay, this is a statute that went into effect in July. So they have a voluntary process. It's initiated by a healthcare provider after an adverse event. And so they have a process they call open discussion. And here's how it starts. The patient receives a letter from the provider to notify them of the desire to enter into an open discussion. And I actually brought a bunch of copies so you can see this letter if you're curious. And then if the patient agrees, they sign and return the consent form. Okay? If the patient wants other people there, like an attorney or family members, those people also have a form that they sign. Okay, the next step is this open discussion takes place. The patient is allowed to terminate the process by giving written notification, and there may be an offer of compensation made. So that's the outline of how the process plays out. It's the details that I want you to think about. Okay, so first of all, only a healthcare provider can initiate this, not a hospital. And they allow up to 180 days since the adverse event before sending the letter. And keep in mind, this is still optional. Okay, no written communication is allowed as part of this open discussion. Only oral. And this provider or facility is allowed but not required to investigate the incident and the care, disclose the results of the investigation, or communicate how future occurrences will be prevented. Again, allowed but not required. And these open discussions, they are privileged and confidential. So privileged means nothing coming out of this could be used as a lawsuit. Confidential means it must be kept secret from everyone not in that discussion. They do point out this privileged and confidential does not include the medical record itself. If a payment of compensation is made, there's no need to report to the National Practitioner Data Bank, and apparently even licensing boards. I want to pause and explain what the National Practitioners Data Bank is. State licensing boards keep track of basically if malpractice payments are made or maybe licensing issues with the physicians in their state. So they should have an idea if a provider has indications they have not able to practice safely, maybe they need more training or maybe they just shouldn't be practicing. So to help keep track of that small number of physicians, so medical state licensing boards have criteria for reporting events to them. The issue is that if a provider who has trouble practicing safely in one state moves to another state, suddenly how would that state know that they have been a problem in a previous state? So the National Practitioner Data Bank is a federal effort for reporting at the federal level, such that for the very, very small number of providers who have patterns of many malpractice claims or issues with their licensing, there's a way to detect this at the federal level. Okay, but for this, there's no need to report. So unlike if there's a settlement or a judgment, those would be reported. Okay, and how do they get around this? Well, The regulations for the reporting to the National Practitioners Data Bank say a malpractice action or claim means a written complaint. This does not begin with anything written by the patient. So that's the loophole. Okay, now that I've gone through that, I want to back up and think, how are these documents different? Must providers tell patients about a harm event? England says yes, Colorado says no. How soon are patients to be notified of a harm event? England says as soon as reasonably practical. And again, it's optional, but Colorado says if you do this process, 180 days. Must patients be told about the event? What must patients be told? England says all the facts about the incident. For these open discussions, there is no requirement for what that patient or family must be told. Absolutely nothing. Are patients giving written communication about the event? It's required by England. It is prohibited in Colorado. Are patients required to keep information they learn confidential? No in England, but yes in Colorado. So in Colorado, patients and families have to keep track pre-existing knowledge versus something they might have learned from these open disclosures, and they can't share anything they learned. I'm very upset too, but I also work with people who like this, and that bothers me. So I'm trying to take a nuanced view.